Okay, so good morning. Our topic for today is cardiovascular diseases. Okay, so what is cardiovascular disease? So your cardiovascular disease, or what we call the CVD, is a general term for conditions affecting our heart, from the word cardio, meaning heart, and then your vascular will be your blood vessel. So it's usually associated with the build-up of your fatty deposits inside your arteries, what we call arteriosclerosis, and an increased risk of blood clot. Okay, so yung mga previous lectures natin, we discuss about the different types of clots, kung paano tayo nagkakaroon ng mga thrombus, nagkakaroon ng embolism. Okay? So ngayon naman, pag-uusapan natin what are the diseases, okay, na pwedeng mangyari or magkaroon kapag yung mga thrombus natin na to nag-block siya into our circulation. Okay? So our vascular cell wall, okay, and the response to injury, so we talk about the injury, kung ano bang nagiging effect, okay, ng ating mga vascular cells or your vascular walls when we are introduced on a certain injury. So the normal endothelial function maintains vessel wall homeostasis and circulatory function through number 1, maintenance of the permeability barrier. Number 2, extracellular matrix production. Number 3 will be the modulation of blood flow and vasomotor tone, regulation of inflammation, and the regulation of your cell growth. As much as possible, di ba, pinag-usapan natin in hemodynamics, okay, the blood should be maintained as liquid as possible unless it is needed to clot. Okay, yun ang pinaka-importante nating tatandaan doon. Ang blood should maintain its fluidity until such time that we need this blood to clot in order to protect us on a certain injury. Okay? So kapag nagkaroon tayo ng problem with your vascular cell wall, nagkakaroon tayo ng tinatawag na mga endothelial dysfunction. So kapag meron tayong mga endothelial dysfunction, so it's usually altered the phenotype that affects the vasoreactivity, induces a thrombogenic surface, or it's abnormally adhesive for inflammatory cell. So kapag nagkaroon tayo ng mga abnormal clotting, okay, so yung mga clotting na yon, didikit siya dun sa wall ng ating mga vessel. So pag dumikit na siya sa mga wall ng ating vessel, madali silang kapitan ng mga inflammatory cell na sumasama during our circulation. Okay? So we have different types of hypertensive vascular diseases. First, we have your hypotension. So from the word hypo, meaning decrease, okay? So it's usually a low pressure. It leads to inadequate organ perfusion, causing dysfunction on tissue death. So ibig sabihin, syempre, kapag meron tayong hypotension, mababa yung pressure or yung distribution ng blood natin into our circulation. So nadideplete ng oxygen supply yung ating mga normal cell. And of course, we have your hypertension. So from the word hyper, meaning increase, there is a high pressure, okay, that causes significant vessel and end organ damage. Siyempre, kapag masyado namang mataas yung pressure, okay, ng ating blood in order to supply our circulation, ang nangyayari naman, nagkakaroon tayo ng problem dun sa ating mga organs. Kasi tatry siyang mag-function ng todo-todo, okay? So in the end, pwede siyang ma-damage. So our blood pressure needs to be maintained within certain pressure in a normal situation, which is around 120 mmHg or 120/80 mmHg. Okay? So, a malignant hypertension is characterized around 200, okay, ang ating systolic. Kapag nasa 200 na mmHg with a diastolic of around 120 mmHg, okay, pwede na natin itong i-consider as a malignant hypertension. Kasi, di ba, napakataas noon. Okay? So kapag meron tayong ganong kataas na blood pressure, it can lead into a renal failure or it can lead into bleeding of our kidney kasi nape-pressure siya. Okay? So the cardiac output is determined, okay, by number one, myocardial contractility, kung gaano ba kabilis mag-contract yung ating heart in order to pump out yung kanyang blood para ma-circulate niya into our circulation. Okay? And then we have your heart rate and of course, the number or yung volume of our blood. Gaano ba kadami yung kailangan niya i-pump? Okay? So the regulation of our normal blood pressure, okay, is a function of your cardiac output and peripheral vascular resistance, which are in turn influenced by genetic and environmental factors. Okay? So your blood volume is affected by your sodium load, okay, your mineral corticoids or your aldosterone, and of course your natriuretic factors that induces sodium excretion. Okay? Kaya nga 'di ba, as much as possible kapag meron tayong problem in kidney, okay, pinapaiwas tayo sa mga maaalat na pagkain. Okay? Number one, kapag mataas din yung blood pressure mo, okay, pinapaiwas ka din sa sobrang maaalat na pagkain kasi as we all know, 'di ba, yung ating kidney plays a major role in the maintenance of your blood pressure. Okay? So dito natin yung tinatawag nating renin-angiotensin-aldosterone mechanism of your hypertension. Okay? So your kidney will play a vital role in the maintenance of your blood pressure. Okay? And then we have your regional autoregulation, which usually occurs when increased blood flow leads to a local vasoconstriction. So kapag meron tayong local vasoconstriction, meaning the constriction of your small blood vessel, syempre kapag lumiit yung daluyan ng dugo, napipilitang mag-pump ng todo-todo yung ating heart in order to supply the circulation. Okay? So kapag lumiliit yung ating mga blood or acidosis, that can cause vasodilation. And of course, your kidney as a major influence on blood pressure by producing renin in the setting of hypotension. Okay, so your kidney will be releasing the renin, okay, in order to convert the angiotensin to angiotensin 1, which is converted into angiotensin 2 that causes your vasoconstriction. Okay, so your angiotensin 2 increases the blood volume by inducing the aldosterone production, which increases your renal sodium absorption. Okay? Kaya nga nare-regulate yung ating blood pressure. So kapag meron tayong decrease or sudden decrease or nagkaroon tayo ng hypotension, magpa-function yung kidney natin, okay, to produce your renin. Okay? Para mag-function yung ating ACE or your angiotensin converting enzymes. The secondary hypertension will cause by intrinsic renal diseases. It can cause by renal artery stenosis, endocrine abnormalities, vascular malformation, and your neurologic disorder. Okay? So it is usually apparent that subtle variation in their activity might influence blood pressure on a broader population. Okay? So kapag nagkakaroon tayo ng hypertension, okay, it usually accelerate the development of your atherosclerosis. Okay, that blocks your blood vessel. So arteriosclerosis is a term denoting arterial wall thickening and loss of elasticity. Okay? So as much as possible, dapat yung mga arteries natin are very elastic in order for us to maintain the normal flow of your circulating blood. Okay? Kapag naging stiff na yung ating mga blood vessel, nahihirapang mag-pass through, lalo-lalo na kung merong mga barado yung ating blood vessel. Unlike kapag medyo elastic siya, Okay, kahit medyo malaki yung volume ng blood na magpa-pass through dun sa area, since elastic siya, nakakayanan niyang mag-pass through yung larger volume ng ating blood. Okay? So there are three patterns in your arteriosclerosis. Okay? So your arteriosclerosis primarily affect the small and medium-sized arteries and arterioles and associated with downstream ischemia. And then we have your Mockenberg medial sclerosis, which is characterized by medial calcification in your muscular arteries, typically occurring after the age 50 years old. As we all know, as we age, di ba, nagkakaroon tayo ng degeneration sa ating mga cells. That is why nagiging prone tayo in any pathological condition. So pag sinabi nating Mockenberg, it is a calcific deposits that are non-obstructive and not usually clinically significant. So your arteriosclerosis is the most frequent and clinically important of all these patterns. Next will be your atherosclerosis. Your atherosclerosis is a slowly progressive disease of large to medium-sized muscular and elastic artery. So they cause pathology by, number one, mechanically obstructing the flora, especially on a small bore vessels, and then plaque rupture leading to vessel thrombosis and weakening the underlying vessel wall and leading to aneurysm formation. Okay? So minsan kasi kaya tayo nagkakaroon ng aneurysm or pumuputok yung ating mga blood vessel kasi hindi na niya nakakayanan yung increased pressure na kung saan, di ba, dinideliver niya yung ating blood into our circulation. Okay? Parang kanal lang naman yan. Ang ating mga blood vessel, parang ano yan parang kanal. Okay? So kapag yung kanal nabaraduhan ng maraming basura, di ba? Maghahanap yan ng butas or pwedeng mag-produce siya ng too much pressure na pwedeng pumutok or doon maglabas, okay, ng kanyang mga water. Okay? So ganun din yung ating mga blood vessel. Kapag hindi na niya kinakaya yung tendency na magkaroon ng aneurysm or pumutok yung ating mga blood vessels. So the constitutional risk factors in ischemic heart disease, we have your age, okay? So as we age around 40 to 60 years old, nag-i-start ng magkaroon ng manifestation yung ating ischemic heart disease. Okay? And next, we have your gender. Okay? Sinasabi nila na ang mga lalaki, okay, mas yung prone sila when it comes to ischemic heart disease kasi siguro sinasabi nila because of yung anong tawag dito, yung kanilang mga habits, okay? And then minsan naman yung mga kababaihan, okay, lumalabas yung kanilang mga risk factors kapag nagkaroon na sila ng postmenopausal. Okay, usually pag after postmenopausal, kapag nag-stop na yung menstruation, okay, nagkakaroon na ng rapidly increase. Okay, minsan na i-exceed na niya yung mga kalalakihan when it comes to the risk factors of having an ischemic heart diseases. Okay? And then we have your genetics. Okay? Family history is the most significant independent risk factor for atherosclerosis. Okay? Kasi alam naman natin, di ba, sinasabi nila, yung ibang mga sakit namamana natin. Okay? Just like with your familial hypercholesterolemia, okay, amounting, nagkakaroon tayo ng higher risk of having this type of disease due to a genetic factor. And then we have your modifiable risk factor in ischemic heart diseases. Okay, we have your hypercholesterolemia, okay, which is the increased risk associated with increased low density lipoprotein or your LDL and decrease in your HDL. Okay, usually kasi our HDL usually clears the cholesterol from our vessel wall lesion. Okay? So, level can be favorably modified by your diet, exercise, moderate alcohol intake, and other enzymes that control our cholesterol. Okay? And then we have your hypertension or your high blood pressure increases the risk of atherosclerotic ischemic heart disease by around 60%. Okay? So both your systolic and your diastolic are important and independent of the risk factors. And of course, we have your DM or your diabetes mellitus, which accelerate your atherosclerosis and doubles the risk of myocardial infarction and increases the risk of stroke or extreme gangrene. Okay? Kaya nga nagkakaroon tayo ng tinatawag na diabetic foot, na kung saan nagkakaroon tayo ng depletion, okay, in oxygen supply, oxygenated blood supply because of your diabetes. Nangingitim yung area, lalong-lalo na dun sa mga lower extremities natin kasi hindi na ganun nasusuplayan ng tama ng ating mga oxygenated blood kasi naka-block, okay, mga barado yung mga ugat dun sa mga area yun. Next, the additional risk factors. Okay, we have your inflammation present at all stages of atherosclerosis. We have your hypocystinemia, elevated levels of homocysteine. We have your metabolic syndrome. And of course, you have your lipoprotein, which is the elevated level confer increased resist of your LDL. And of course, we have your hemostatic factors. We go now with aneurysm and dissection. So what is an aneurysm? So aneurysm, these are your congenital or acquired dilation of your blood vessels of the heart. While your dissection occurs when blood enters the wall of a vessel and separates the various layer. So we have main types of aneurysm. We have your true and we have your false type of aneurysm. When we say your true aneurysm, it involves all three layers of the artery. So you have your intima, your media, and your adventitia layer of your artery, or the attenuated wall of your heart. Okay? So your false aneurysm is also called pseudoaneurysm. Okay? It usually results when a wall defect leads to formation of your extravascular hematoma that communicates with an intravascular pulsating hematoma. Okay? So your aneurysm and dissection are important causes of your stasis or your thrombosis. Okay? So kapag nagkakaroon tayo ng aneurysm and dissection, okay, kaya tayo, ang important causes nito kung bakit nagkakaroon tayo nito is because of your thrombosis or your abnormal, okay, clotting of your blood. Next, we have your aneurysm classified by shape. We have your saccular and we have your fusiform type of your aneurysm. So your saccular, this is a discrete pouching around 5 to 20 centimeter in diameter. While your fusiform, these are circumferential dilation and go up to 20 centimeter maximum in diameter. So your aneurysm occurs when connective tissue function is compromised by your number one, abnormal or inadequate connective tissue synthesis, excessive connective tissue degradation, and of course, loss of smooth muscle cell or change in your synthetic phenotype of SMC. We go now with your aortic aneurysm. Your aortic aneurysm is mostly caused by atherosclerosis and hypertension. Arteries are dynamic tissue that maintains the integrity through the ongoing synthesis, degradation, and repair of your extracellular matrix. So your atherosclerosis are the more dominant factor of your aortic aneurysm and hypertension, particularly on the ascending aortic aneurysm. So the factors that weaken your vessel wall, it can be due to trauma, congenital defects, o kung meron kang hereditary defects upon inborn congenital defects in your heart, okay? It can lead to aortic aneurysm. And of course, you have your vasculitis and your infection. So your abdominal aortic aneurysm or your AAA typically occur between your renal arteries and aortic bifurcation. Okay, so usually occurs in the abdominal aorta but it can also involve common iliac arteries, aortic arch, and descending thoracic aorta. It usually develops after 50 years and more common in smokers, lalong-lalo na sa mga kalalakihan. Okay? So, the atherosclerotic plaque causes arterial wall thinning. Okay? So, lumiliit yung ating artery. So, your atherosclerotic plaque compromise the diffusion of your nutrient and waste between your vascular lumen and your arterial wall. So your wall thinning is a familiar predisposition of your abdominal aortic aneurysm. Okay? So we have your inflammatory type and we have your mycotic type of abdominal aortic aneurysm. So your mycotic abdominal aortic aneurysm, usually it results suppuration, accelerate the medial destruction, and may lead to rapid dilation and rupture of your blood vessel. And then we have your clinical consequences of your AAA. We have your obstruction of vessel branching. We have your embolism or your thrombus that came or join your blood circulation and block the other parts of your circulation. And then we have your impingement of adjacent structure, abdominal mass that simulates a tumor, and of course, there's rupture in the peritoneal cavity. And then we have your thoracic aortic aneurysm, which is commonly associated with hypertension and your Marfan syndromes. So your signs and symptoms include persistent cough, pain caused by erosion of the bone, cardiac disease due to valvular insufficiency, and narrowing of your coronary area. Next, we have your aortic dissection. So your aortic dissection occurs when blood splays apart from the laminar plane of your media to form a blood-filled channel within the aortic wall. Okay? So mostly the dissection to intimal tear marking point in the ascending aorta, and the tear usually around 1 to 5 centimeter long. Okay? Mainly occurs in age group around 40 to 60 years old. Okay? So we have two types of dissection. We have your proximal type of lesion and we have your distal lesion or your type B dissection. Next, we go now with your vasculitis. Okay? So from the word itis, meaning inflammation, so it is a general term for vessel wall inflammation. Okay? The signs and symptoms include systemic inflammation such as fibromyalgia, okay? Malaise, and arthralgias. Has predilection for large vessel and most affect small vessel like your arterioles, the capillaries, and your venules. Next, we go now with your veins and lymphatics. Okay, so we have your varicose veins. Okay, these are abnormally dilated tortuous veins produce chronically increased intraluminal pressure and weakened vessel wall support. Okay, so your varicose veins and phlebothrombosis or your thrombophlebitis account for 90% of clinically type venous diseases. So your varicose, 20% for men and around 33% for women, and usually we can see them on your lower extremity area. Okay, ito yung mga kulay blue na usually makikita nyo dun sa likod ng inyong mga tuhod na parang nangangalit na mga blood vessel. Okay, so we have varicose on the other sides. Okay, we can see it on esophagus or your esophageal varices. And of course, you have your hemorrhoids or your almoranas. Okay, so your hemorrhoids, these are varicose dilation of the venous plexus at the anorectal region that result in prolonged pelvic vascular congestion associated with pregnancy or straining to defecate. Okay, yung hirap pumupo. Okay, so madalas sa madalas, yung mga hemorrhoids na to, di ba, kapag medyo malalaki na sila, or your phlebothrombosis, Okay? So these are thrombosis of your deep leg veins, accounts for 90% of the cases of thrombophlebitis and phlebothrombosis. The symptoms usually absent, lack of finding, okay? So it does not exclude your deep vein thrombosis or your deep venous thrombosis. Okay? So madalas, these thrombi tend to produce few or any other reliable symptoms, and pain can be elicited by forced dorsiflexion of foot and squeezing of your calf muscle. Okay? Next, we have your superior vena cava syndrome, okay, caused by your neoplasm that compress or invade the superior vena cava, such as bronchogenic carcinoma or your mediastinal lymphoma. And of course, we have your inferior vena cava syndrome, okay, can be caused by neoplasm that compresses or invade the inferior vena cava or by thrombus from hepatic, renal, or lower extremity vein that propagates upward. Next, we have your lymphangitis and lymphedema, which are primary disorder of your lymphatic vessel that are extremely uncommon. It can cause secondarily by lymphangitis, okay, or your acute inflammatory process caused by bacterial seeding of the lymphatic vessel. We have your primary lymphedema, and of course, your secondary or obstructive type of lymphedema. Okay, from the word obstructive, okay, it can obstruct on the previously normal lymphatics. Another cause will be your tumor. Okay, so your primary tumor of blood vessels and lymphatics run the gamut from common benign hemangiomas to intermediate or frequently locally aggressive lesion to rare such as your malignant angiosarcoma. So your congenital or developmental malformation and non-neoplastic reactive vascular proliferation, example will be your bacillary angiomatosis, can also present as a tumor-like lesions. So these are your benign tumors and tumor-like condition. We have your hempangioma or your hemangiomas, which are common lesion accounting to 7% of all your benign pediatric tumors. We have your capillary hemangiomas, which are common type of your vascular tumor. And of course, you have your cavernous hemangiomas, which is an addition to the skin, the liver, and common site. This can be locally destructive and generally do not regress into a more malignant type. And of course, we have your pyogenic granuloma, which are ulcerated, polypoid variant of capillary hemangiomas, open following trauma. Okay? Usually, it is composed of proliferating capillaries with intersphere edema and inflammatory infiltrates that resemble an exuberant granulation tissue. Next, we have your lymphangiomas. These are your benign lymphatic analogs of hemangiomas. We have the two types. We have your capillary or your simple lymphangiomas. And of course, we have your cavernous or your cystic type of hygromas. Next, we have your glomus tumor or your glomangioma. Okay? It is a benign, exquisitely painful tumor of modified smooth muscle cells arising from the glomus of the body, which is a specialized arteriovenous structure involved in your thermoregulation. So when you say arteriovenous, meaning there more or probably these are the areas wherein your arteries or your vein meets, okay, to exchange from oxygenated to unoxygenated type of your blood. So these tumors occur most commonly in the distal phalanges, specifically beneath the nail beds. Okay? So nandito yung ating mga areas no kung saan yung ating extremities. These are where areas of the exchange oxygenated to non-oxygenated blood. Okay? Next, we have your malignant tumors. We have your angiosarcoma. Okay? From the word angio, meaning blood vessel, and of course, sarcoma, meaning mesenchymal in origin. Okay? These are malignant endothelial neoplasm on an spectrum from well-differentiated to anaplastic type. It can also be developed in a long-term chronic lymphedema. Next, we have your hemangiopericytoma, which are pericyte tumors commonly arising on the lower extremities. Okay, 50% of the metastases. It usually presents as a slow enlarging painless mass that consists of branching capillary channel encased by nests and masses of spindle shape to round cell extrinsic to your extracellular basement membrane. We go now with your heart. Okay? So what are the effects of aging on our heart itself? Okay? Habang tumatanda tayo, rumurupok yung ating puso, okay? Nagkakaroon tayo ng problem into our heart because siguro, syempre, because of too much use, okay? Pagod na, okay? So nagkakaroon tayo ng degeneration of our heart. So the effect will be reduced ventricular cavity size. We have your valve sclerosis and calcification leading to stenosis. We have your valve degenerative changes leading to insufficiency. And of course, we have your reduced myocyte number and increased interstitial fibrosis causing reduced contractility and compliance. So habang tumatanda yung ating puso, okay, nagkakaroon tayo ng decrease in contraction. Okay? Kasi nagkakaroon na tayo ng decrease in number of cells, nag-i-increase tayo in the cellular shape and cellular size. Okay? So heart disease, okay, what are the overview of pathophysiology of your heart diseases? So our heart disease is the leading cause of morbidity and death worldwide. It usually accounts 40% of deaths in the United States. Okay, so your cardiac disease occurs as a consequence of one or more of the following general mechanism. Number one, failure to pump due to either poor contractile function. We have your blood flow obstruction because of your atherosclerosis. We have your regurgitation flow, okay, na kung saan bumabalik, okay, yung ating na-pump the blood kasi insufficient, okay? And then we have your shunt that allows abnormal blood flow, abnormal cardiac conduction leading to uncoordinated myocardial contraction, and of course, we have your rupture of the heart or major vessel. First of all, the heart of all the heart diseases will be your heart failure. Okay, your congestive heart failure is the common endpoint of your many factors of heart diseases. It is usually occurs when an impaired function renders the heart unable to maintain output sufficient for metabolic requirements of the body, or when can only do so at elevated filling pressure. Okay, your CHF is characterized by diminished cardiac output, accumulation of blood in the venous system, okay, or both. So it is most frequently of the heart failure occurs due to progressive deterioration of our myocardial contractile function. Okay? Next, we have your Frank-Starling mechanism, which is the increased filling pressure that dilates the heart, thereby increasing functional cross-bridge formation within sarcomeres and enhancing contractility. And of course, we have your myocardial hypertrophy, okay, which is increased expression of the contractile apparatus protein. We go now with atrial septal defect. It is the most common congenital cardiac anomalies seen in adult. So even large arterial septal defects are usually asymptomatic until adulthood. So when either right-sided heart failure can occur or right-sided hypertrophy and pulmonary hypertension can induce right-to-left shunting with cyanosis or your bluish discoloration. Okay? So we have types of your ASD. We have your prenum type, around 5% of all the ASD. We have your secundum type, around 90%. And we have your sinus venous type, around 5% of your atrial septal defect. Next, we have your ventricular septal defect. It is the most common congenital cardiac anomaly overall. It is it can surgically corrected if desirable before right-sided overload and pulmonary hypertension can develop. Okay. Next, we have your patent ductus arteriosus or your PDA. So it is your ductus normally closes within 1 to 2 days of life, depending on its caliber. Most are initially asymptomatic but produce a harsh continuous machinery like hurt murmur. Okay, so 90% of the remainder are associated with your ventricular septal defect or your stenosis. So the large PDA or your patent ductus arteriosus causes right-sided volume and your pressure overload. So with your early closure surgically, okay, it can advocate into a less complication in the near future. Next, we have your tetralogy of your follow-up. So the cardiac findings are we have your ventricular septal defect, we have your pulmonary stenosis with right ventricular outflow, obstruction, we have your overriding aorta, and of course your right ventricular hypertrophy. Okay, so with complete pulmonary obstruction, survival can occur only by flow through a PDA or dilated bronchial arteries. So with a large ventricular septal defect, and a mild pulmonary stenosis, there's a minimal left to right shunt and no cyanosis or bluish discoloration at all. Next, we have your ischemic heart disease. Okay? It is a compromised multiple pathophysiologically related syndrome related to myocardial ischemia that is mismatched between cardiac demand and vascular supply of your oxygenated blood. So the consequences of your ischemic heart disease, you have your oxygen insufficiency or your hypoxia or anoxia that can lead into cellular death in the near future because of the depletion of your oxygenated blood. There is an inadequate nutrition, okay, on the area, and there is a diminished metabolite removal. Next, we have your ischemia can lead into three possible causes. We have your reduced coronary blood flow. It can increase myocardial defect demand, like your tachycardia or your hypertrophy. It can lead to hypoxia because of your diminished oxygen transport. So there are four overlapping ischemic syndrome. Okay, we have your angina pectoris, we have your myocardial infarction, and there's a sudden cardiac death or shock. Next, we have your angina pectoris, which is a paroxysmal substernal pain, ischemia duration and severity, and no sufficient that cause infarction or cellular death. Okay, so there are three patterns. We have your stable angina. We have your metal angina due to vasospasm. And of course, we have your crescendo angina, which is a pattern of pain occurring with successive lesser amount of exertion or even at rest. Next, we have your MI or your myocardial infarction, wherein your myocyte cell death caused by vascular occlusion. We have your chronic ischemic heart disease, okay, which is a progressive heart failure due to ischemic myocardial damage. It may result from post-infarction cardiac decompensation of slow ischemic myocyte degeneration. It can, microscopically, there is a myocyte hypertrophy, a diffuse subendocardial myocyte vacuolization, and interstitial and replacement of fibrosis or fibrotic cells on the area. Next, you have your sudden cardiac death, which is defined as the unexpected cardiac death within 1 hour of symptoms onset. Okay, so from the word sudden, meaning immediate. pwede siyang mamatay within 1 hour na kung saan naramdaman niya yung symptoms. Okay? So your SCD is an infrequently a consequence of your myocardial hypertrophy. Okay? So it is hereditary or acquired conduction system abnormalities, electrolyte derangements, mitral valve prolapse, myocardial deposition, or your myocarditis. So these are just the different types of heart diseases. Okay, these are just summary of your heart diseases. Okay, you have your mitral valve prolapse, rheumatic fever, and rheumatic heart disease. Okay, we have your infective endocarditis and your non-bacterial thrombotic endocarditis. So kapag mayroong sakit sa puso ang ating pasyente, particularly infective endocarditis, okay, that is the time na hindi natin siya basta-basta pwedeng bunutan or basta-basta mag-induce tayo ng bleeding. Kahit regular oral prophylaxis lang, medyo delikado sa kanya. Kasi pwedeng mag-cause siya ng increase in microorganism dun sa loob ng kanyang heart, okay, that can lead into bacteremia or infective endocarditis. So kapag ang mga pasyente meron siyang ganito, usually piniprescribean muna siya ng 2,000 grams or 2,000 milligrams of your antibiotics an hour before your surgical procedure or your regular oral prophylaxis. So apat na 500 milligrams ng antibiotics pinapainom natin sa pasyente, okay, an hour before his or her scheduled surgical procedure. Okay? So we have your endocarditis of systemic lupus erythematosus, and we have your carcinoid heart disease. We go now with your cardiomyopathy. So your cardiomyopathy is a principal cardiac dysfunction. So there are three main functional pathological patterns. We have your dilated cardiomyopathy, we have your hypertrophic cardiomyopathy, and of course, we have your restrictive cardiomyopathy. Okay? So your pericardial disease, it is atypically secondarily to disease of adjacent structure or part of the systemic disorder. Okay? So it is slow fluid accumulation resulting in chronic collection of greater than 500 ml, and rapidly accumulated fluid can cause fatal tamponage with as little as around 200 ml. So we have your pericarditis, which is a secondarily to disorder involving the heart or mediastinal structure. Okay, so our heart is surrounded or covered by your pericardium. So kapag nagkaroon na tayo ng abnormal fluid accumulation on that area, it can lead into a pericardial disease. Okay, so we have two types of pericarditis. We have your acute pericarditis. Okay, so under your acute pericarditis, we have your serous, we have your fibrinous, and we have your purulent or suppurative type of pericarditis. So pag sinabi nating serous, medyo liquid, watery-like yung area. Okay, kapag fibrinoid, meron tayong mga fibrous tissue. Okay, and then kapag purulent, meron na tayong tinatawag na pus-like structure. Okay? So, purulent or suppurative, medyo meron ng nana dun sa area. Okay? And then we have your hemorrhagic pericarditis. From the word hemorrhagic, it means blood on the area. And of course, we have your caseous type of pericarditis from the word caseous, meaning cheesy-like yung area. May mga whitish spots dun sa area, just like with your caseous necrosis of the lungs. Okay? So, medyo meron siyang combination of your coagulative type and your suppurative type of inflammation. Okay? And then we have sac. Okay? So the heart contracts against all the surrounding attached structure with subsequent hypertrophy and dilation. And of course, we have your constrictive pericarditis, which is a thick, dense fibrous obliteration, often with calcification of the pericardial sac encasing the heart, limiting diastolic expansion and restricting our cardiac output. So, kaya nagkakaroon tayo ng restriction in the cardiac output, nagkakaroon tayo ng constriction on the area, thus limiting the contractility function of our heart. Okay? Next, we have your tumors of the heart, we have your myxomas, and we have your lipomas. Okay, so your myxomas, these are most commonly primary cardiac tumor in adults. Around 90% rises in the left atrium of the region of the fossa ovale. Okay, and then we have your lipomas, which are well-circumscribed benign accumulation of adipose tissues, commonly in the left ventricle, right atrium, and the septum of the heart. Ito yung nababalutan na ng taba. Okay, yung area. Okay, meron tayong mga lipomas or we have your adipose tissue accumulation on the area. Okay. Next, we have your papillary fibroelastomas, which are sea animal-like lesion with filaments radiating out from a certain core. Microscopically, the filaments have a core of myxoid connective tissue with concentric elastic fibers all covered by your endothelium. So, another tumors will be your rhabdomyomas, which is most commonly primary heart tumor in children, cause valvular and outflow tract obstruction. So your rhabdomyosarcomas, these are your malignant neoplasm resembling their counterpart in the other location of your body. Okay, so it can be seen microscopically with large rounded topologinal cell rich in glycogen and containing myofibrils. Okay. So this is an example of the tumors in the heart area. Next will be your cardiac transplantation. Okay? So most probably, ito yung pinakamahirap siguro na masasabi natin na magkaroon ng donor. Diba? Sabi nga nila, diba, sino bang magbibigay ng puso? Okay? So it is usually performed for DCM and ischemic heart disease. When we say DCM, these are dilated cardiomyopathy. Okay? So actually, Dr. Juan is candidate noon for cardiac transplantation. Kaya lang medyo walang nahihirapan dun sa magiging donor. Kaya galit na galit yun dati kapag nakakakita siya ng mga EJK or yung mga extrajudicial killing na kung saan pinapatay lang. Sana man lang, sabi niya, sana na-donate na lang yung mga puso nila, sayang. Dun sa mga taong gusto pang mabuhay. Okay? So, si Dr. Juan, nakamatayan na niya, okay, yung kanyang paghihintay na magiging donor. So, your DCM or your dilated cardiomyopathy, so these are a major current long-term limitation of your cardiac transplantation, which led to progressive diffuse intimal proliferation of the coronary arteries, causing downstream myocardial ischemia. Okay? So we have your acute allograft rejection characterized by interstitial lymphocytic inflammation with associated myocyte damage. We can also have an inflammatory vascular injury, and there's an extensive myocyte necrosis. So during cardiac transplantation, there's also the possibility na magkaroon pa rin tayo ng acute allograft rejection on the area. Okay? Kasi hindi naman siya normaling sa'yo yan, pwede pa rin i-reject yan ng ating katawan. Okay? Pwede niyang sabihin, this is tawag dito, foreign body material na inilagay doon sa area. So after transplantation, of course, our WBCs will go on the site of injury and inflammation. Okay? They will try to kill yung ating mga foreign body materials na inilagay doon. Pero if our body will not will adapt on that certain condition, okay, magkakaroon tayo ng pwedeng i-accept na ng ating body system etong bagong transplanted heart na to. Okay? So I think that's the last part of the lecture. So as a parting word, success is no accident. It is a hard work, perseverance, learning, studying, sacrifice, and most of all, love you are doing or learning to do. Lagi niyong tatandaan yon, okay? Ang success, hindi yan walk in the park. Okay? It is a product of your perseverance and sacrifices. Again, magandang umaga sa inyong lahat. Okay? Okay, any questions regarding our topic? Okay, so